Hi friends, I am Dr. 𝐒𝐏𝐄𝐑. Today again coming back to you. And before you, she is 𝐒𝐀𝐍𝐉𝐈 from 𝐒𝐀𝐍𝐉𝐈. She was brought here before about a week at around 10 p.m. in the night, intubated on a ambush bag, totally unconscious, and we examined her. At that time her blood pressure was normal but supported by some inotrope, noradrenaline, and she was intubated. She was unconscious, responding to painful stimulus, but not fully oriented. Her pulse rate was normal. Now the history was such that she was admitted for fever in some hospital in Udaipur, where she was recovering well. She was in the ward. Suddenly she developed convulsions, and then she had to be intubated and put on a ventilator. The convulsion was not notified in the hospital, they were not recorded, but she became unconscious, so they thought it was convulsion. And then patient was referred here. Here in our hospital, when we saw her platelet counts were low, her SGPT was high. Platelet was around 40,000, SGPT was in the range of 250-300. Her hemoglobin was normal, her blood WBC count was borderline high, around 15,000. Her creatinine was normal, and electrolytes were also normal. So we gave supportive medicines in form of broad spectrum antibiotics, ventilatory support, IV fluid, and suspecting some atypical infection, atypical fever, atypical hemorrhagic fever, we also added intravenous doxycycline on the day one itself. And we investigated this patient by sending CBC, RFT, LFT, and along with that we sent dengue, malaria, typhoid, scrub typhus, and leptospira. Crimean Congo was unlikely, so we did not send the serology for Crimean Congo. On the second day, patient became conscious. Third day, we extubated her, and on the third day evening, we got the report that she is having scrub typhus positive. So her treatment was right. She was already on doxycycline and slowly improving. On around 5th day morning, we were thinking of shifting her to ward, and suddenly she developed ventricular fibrillation. She became unconscious. The monitor straightway showed VF. Immediately DC shock was given, patient was revived, and we gave her amiodarone. Then after 1 hour, again she developed ventricular fibrillation. Again DC shock was given, again we revived her, and amiodarone was continued. We did a bloodline echo. Echo was showing mild LV dysfunction, otherwise mota-moti echo was normal. So what is this? It has been rarely reported internationally that some patients of scrub typhus can develop myocarditis. Myocarditis is a definite but very rare complication of scrub typhus, and due to irritable myocardium, they can throw up arrhythmias, and this can lead to death. So probably the first episode which had occurred in Udaipur must also be some sort of arrhythmia which was treated as seizure. So now she is recovered well. We have corrected all electrolytes which were even borderline abnormal. Today we are discharging her. She is asymptomatic since last 3 days with normal ECG. She is now not on any anti-arrhythmic drug. We are just discharging her with multivitamins and doxycycline. Thank you so much, because I feel privileged to share certain rare cases like this. कैसा है आपको? अच्छा है ना? भैया कैसा रहा है इलाज?
अच्छा रहा।
आपको संतोष है पूरा? आप लाए थे उससे फायदा अच्छा हो गया?
अच्छा नहीं हुआ, हमारी बच गई है।
अच्छा अच्छा हुआ,
हमारा पेशेंट अच्छा हुआ है,
बहुत अच्छा हुआ।
बहुत अच्छा हुआ है।
हमारे वीडियो को देखते तो हमारे
आपको पूरा संतोष है।
पूरा संतोष है।
थैंक यू, थैंक यू।
Thank you.
हाँ डॉक्टर अश्विन, आपका क्या कहना है?
Yes, sir, definitely. It is a rare case because of complicated myocarditis. She developed ventricular fibrillation, video shock, disease shock, reverse, 2 times reverse. So we can call it is a good case, good experience. Today she is discharged. We are happy, relatives are happy. So thank you.
We also gave empirically hydrocortisone for 3 days. Though literature does not say that there is any role of steroid, but on the safer side, hydrocortisone was given, antiarrhythmic was given, and doxycycline was continued, and she is fully recovered. Thank you.